we have the pleasure of welcoming Jean Gaudart from Aix Marseille University. And he will talk to us about spatial heterogeneity in COVID-19, right? It's the short version. Right, please, whenever you're ready.
Okay, thank you. I will share my screen. Oh, mais il faut pas que je fasse ça. How can I share my screen?
The green, la flèche verte en bas.
Oh, yes. Okay.
Ah, voilà.
Ah, pourquoi ça marche pas? Ah, okay. Do you see my slides?
That's fine.
Yeah.
Okay, thank you.
Right.
So please forgive my awful English. I will try to be understandable as much as possible. But I will try to speak about the spatial heterogeneity of the first wave of COVID-19 in France. And we applied a nationwide geo-epidemiological study on this data set. Just to mention the big group working with me, I'm not alone. And I'm part of the Institute of Public Health Sciences from Aix Marseille University, and the team is a CES team pour sciences économiques et sociales de la santé et traitement de l'information médicale. Then you know already that the first wave in France began officially on January. I just saw today publications saying that probably it began in France in November 2019. But the first official cases in Europe and in France was 3 cases in Bordeaux and Paris in January 24. And then in February, we have experienced 4 clusters. One in one big cluster in Haut-Rhin, the northern eastern part of France, with a big religious meeting. Another one in Oise, just near Paris, in military camp, and one small in Haute-Savoie, in the mountain and in the Alps, and another in Morbihan, in the Brittany region of France. Then on March, the 5th of March, began the first mitigation measures. And before the lockdown, there was again the first round of the municipal elections on March 15, and the lockdown was applied on March 17. The peak of the first wave is estimated on March 31, even if you can see the big number of cases in April, but this is the correction of the database, the national database. So at the peak, we counted for 7,500 of new confirmed cases per day. And then the wave began to stop until the end of the lockdown in May 11. So during this period, we experienced roughly 200,000 cases and 30,000 of deaths. But about the data, the problem in France that we didn't have a national information system able to count for cases. We only had some different hospital information system, not connected ones, and no national surveillance system. The first information system was developed on March 19 and was based on hospital information system. It was a system called Civic. We can use it today again for counting for the hospital cases and the hospital death. So that data we are looking for were data from March 19 and May 11. for case and death. So the aim of our study was to assess for spatial heterogeneity of 3 outcomes. Hospital incidence rate, I mean hospital because the data for in population was not available at that time. So incidence rate estimated by the cumulative number of in-hospital COVID-19 cases per 100,000 inhabitants. The mortality rate, in-hospital mortality rate, similarly estimated, and the case fatality rate. It's a number of deaths by the number of hospital cases. So, and the second aim was to assess for factors associated with these 3 outcomes. In terms of methodology, assessing for spatial heterogeneity is not difficult. So we provide maps and one global indicator for spatial clustering, the Moran I, and we use the Queen contiguity matrix for that. Assessing for factors associated with the 3 outcomes was more difficult because a lot of factors have been associated with the disease and the spread of the outbreak. So we defined different factors. The first one was the lockdown. So, but the problem of the lockdown is not the date of the lockdown, who is very important, but the time of the lockdown, considering the spread of the outbreaks, the local epidemic onset. So we define this characteristic as the difference between March 17, the national lockdown, and the first death date. So some departments, some French departments experienced the first date before the lockdown, and other departments experienced the first death after the lockdown. Then age and sex have been associated with the disease and mainly the severe COVID-19 and death. So we used the population structure, age and sex structure, estimated at the department level. The access to healthcare services are also very important and the baseline population health. But we don't have nationally information about the number of cardiovascular disease or diabetes or obesity, etc. So we use the number of, for example, of hospital beds, the number of medical doctor, of nurse, of hospitals, also nurses, home nurses, nurses who are going to practice at home, mainly for elder people, etc. So a lot of different health characteristics for each department. Similarly, we use different economic indicators because it has been published, and we can see it also every day, that poor people have less access to the tests and less access to healthcare services. So we use different French indicators for economic status, for economic level at the department level. Urbanization is also another important characteristic, as the population density is very important because in remote rural area, population are less affected by the disease, mainly because there are less people in contact with other people. So we use different characteristics based on the population density, the number of departmental routes, road, etc. And finally, we used also climate characteristics, but we didn't use the meteorological characteristics such as rainfall and temperature and so on, because we only have some estimations and it's more difficult to aggregate data at the department level. So we use climate factors based on geographical analysis. But we did have a lot of factors, covariates, and a lot of these covariates were linked together. For example, the age and the number of nurses going at home for practicing cares for elder people, so these different characteristics are linked. And so we used a method proposed by Lee, Josie, and Husson based on principal component analysis, then hierarchical ascendant classification to classify all these cofactors. Oh, not all, but at least age and sex structure, baseline population health and healthcare services, economic indicators, urbanization, and climate. I forget to say that also we analyze the consumption, the dispensation of some drugs who were firstly declared as impacting the impacting the COVID-19 outbreak. So then we analyze the data using a regressive approach based on the generalized additive model from Simon Wood works. First, we use the negative binomial distribution to take into account overdispersion. We use the log population as an offset to estimate standardized ratio, that is standardized incidence ratio, standardized mortality ratio, and standardized fatality ratios. We also use spline function to estimate, to look for nonlinear relationships. And then to take into account spatial autocorrelation, we use the Gaussian process smoother based on a power exponential model for a covariance function. And you can have the two main reference for these approaches. But you know, we are applying an ecological study. So because we are working on aggregated data, so we have had ecological bias. So we try to validate our approach. First, the classification approach was validated by simulated data. But also we applied an old method, the Swantrade method for covariate space size reduction based on the Torgerson distance to select one factor among a group of factors. The second validation was based on a sensitivity analysis by substitution. That means we changed our outcomes. We had 3 outcomes: incidence, hospital mortality, and hospital case fatality rate. And we did change, substitute these 3 outcomes. So we tried to explain allergies by lockdown, by urbanization, by healthcare, by population, age structure, etc. So normally, if we get any relationships between allergies and lockdown, that means that we have an ecological bias. If we don't get any link, so we can assume that the ecological bias is reduced, have been reduced. So first, the results. We had, during the period, we had 100,000 hospitalized in hospital cases and 17,000 severe cases. And you can see the map with showing the spatial heterogeneity. The spatial heterogeneity was significant, and the incidences ranged from 20 to 500 cases per 100,000 inhabitants. As an example, the two main area, the Paris area in the north and central part of France, with 400 cases per 100,000 inhabitants, and the Bouches-du-Rhône, that means the Marseille in the southern part, Marseille area, with 200 cases per 100,000 inhabitants. In the mortality, we have the same spatial heterogeneity. And you can look for the two, you can see for the two maps, the Rhône canal, the Rhône corridor, from the northern part of France to the southern part of France, which is classical in French outbreak, and also in old outbreaks. For example, in the plague outbreaks, we can see this corridor with a high density of population and a lot of mobility of people and goods. What you can also, I can also mention that the case fatality rate was also different from place to place, but a less clear spatial pattern. In the southern part of France, I also would like to mention that the Marseille department, the Bouches-du-Rhône department, even if it was affected at a lower rate than the other part of France, was affected by a higher rate according to the surrounding department of the area. You can see that for the incidences, but also for the mortality. So about we can see this, what I mean just now, on the deviation to the mean, as you can see the southern part of France was lower than the national incidence, national mean, but Marseille, the Bouches-du-Rhône department, was affected by a higher rate than the surrounding department. It's less obvious for the mortality, but it's more in the mean about the mortality than in the incidence when it's highly affected. Now, what about the cofactors? And here I will show you only the multivariate analysis. So the main result is that the lockdown was effective. That means that it reduced the lockdown, here the map of the lockdown, it reduced the spread of the outbreak. And this is the standardized incidence ratio for each day, for each delay on the lockdown according to the outbreak spread. And for one day, when one day late, will increase the incidence and the mortality and the case fatality rate. So the earlier, the better. The urbanization was not significantly associated with the incidence, but we still let this characteristic as an adjustment of the covariate. The climate factors was also not associated with the incidence. This could be explained by the lack of variation of the climate in France at this period of time, and also by the important high wave according to the outbreak, the importance of the outbreak, and the low variability of the climate in France. So maybe it was not an important, climate was not an important factor for this spread. At this scale, if you, there are other work on different scale, mainly on comparing different countries that shows that the climate could be important, an important factors for the spread of the outbreak. The population age structure was important at this scale, and this is very interesting because, again, we didn't have individual data. We only worked with aggregated data. And the age characteristic of the department at the department level was important to estimate the mortality and the case fatality rate. That means if we compare the mortality from part to part, from one region to another, from one country to another, it's important to take into account the population age structure. So we cannot compare Brazil and France, for example, because the age structure is very different. And also we cannot compare Mali and France, as Mali in West Africa has a very lower age structure than France, for example. The other characteristic, baseline population health service, health and healthcare services were not associated with the incidence and the mortality, and we will discuss that later. A very interesting, I didn't mention it before, but a very strange result for us was the absence of the association between incidence, mortality, and fatality rate and intensive care unit beds. But note that the number of beds in 2020 was not available and is not available at this time. So we used the previous intensive care unit beds as an information about the healthcare capacity. But this number, ICU beds in 2018, was not associated with mortality. And this means something. I will discuss this later. The two last factors were the economic one, was absolutely not related to incidence, mortality, or fatality rates, so we excluded from the multivariate analysis. And the last one was the chloroquine dispensation, and was highly associated in the univariate analysis, but with a bias by indication. That means the area with the higher number of dispensation where Paris area where the number of cases was the highest. But in the multivariate analysis, there was absolutely no relationship between chloroquine and the spatial heterogeneity and the spatial no relationship between chloroquine and the incidence rate and the mortality rate, nor the case fatality rate. As a discussion, first we saw the clear spatial heterogeneity of the incidence and mortality, and the map is showing the spread of the epidemic before the lockdown. And one of the main interesting results showed for individual data, but we showed it for aggregated data, or regional data. The population age structure is associated with the in-hospital deaths. This is also, again, an important information when we compare countries. The climate and economic indicators are not associated. First, it's because we don't work on individual data about the economic indicators, but on aggregated data. And there are a few variations between departments in France. But for different periods of time or different countries, these indicators could be associated with incidence and mortality. One strange result for us, but very interesting one, was the lack of association between intensive care unit beds from 2018 and healthcare services. There was no association to in-hospital deaths. This could be interpreted as a good hospital reorganization to absorb the shock. This is our interpretation. That means even if the number of beds or healthcare services were not very, were low in certain departments. Because of the outbreak, there was a big reorganization, and this was effective to absorb the shock. That's why we didn't see any relationship of the baseline healthcare services and the in-hospital death. The last and very important result is for this first wave, and in health point of view, the lockdown was very efficacious. There was the lockdown efficacy on hospital incidence, mortality, and case fatality rate was shown by our study, and the earlier the better. Even when adjusted on the populational structure, urbanization, climate, healthcare services, and proposed treatment at that time. This also underlines the weakness of the French preventive and public health organization. That means without any lockdown, we could expect a much higher number of deaths. So because we in France, we were not prepared to apply preventive measures, and for example, we didn't have any surveillance or epidemiological information system, so we were not prepared to this kind of outbreak. So we have two very interesting, in our point of view, results, that the hospital reorganization did absorb the shock. In France, we are based on a public hospital system, but the second conclusion is we have a very weak preventive and public health organization. The current situation is very different, as these are the map of the in-hospital incidents after the first of September 2020 in incidence and mortality, and it's much more difficult to see any pattern, spatial pattern. We still see that the Territoire de Belfort is highly affected, and the south and eastern part of France is highly affected. But it's the second wave, or the second and third wave, are very different than the first one. And here are the trend for the current situation. You can see the second wave, which began in July. In blue, it's the number of tests per 100,000 inhabitants, and in red are the positive cases per 100,000 inhabitants. And you can see even if the velocity of the outbreak is not very high, we assume that the next peak will be higher than the last one. And we can see the hospitalization and the intensive care unit. And we can see that the number of hospitalization was about the same from the second wave and the first wave. And ICU admission was slightly lower, but the number of admission is still growing, unfortunately. So thank you for your attention.
Thank you, Jean, for a very nice talk. So now it's question time. So if you have a question in the attendance, please raise your hand and or use the chat to ask the question, and I will allow you to talk. So in the meantime,
Jean Wang just had the question.
Oh, Jean Wang had the question.
Hi, John. It's Jiang Hong. My question for your early comments saying lockdown works. So in the first wave in France, the lockdown is the countrywide, or is by regions, region by regions?
Countrywide.
Countrywide. Okay, good. Yeah. So that's my. So what if you? This is suspect. So what if you have region specific or city specific lockdown. So for example, if you look down only in Paris, if you did outbreak in Paris, did that happen in France, actually, the second wave, you did also countrywide or region specific?
We had some difference in the mitigation measures. The couvre-feu, how do you say in English? Curfew was different from place to place. For example, in southern France was we experienced the first in September the curfew, and then later in the other part. But for the lockdown, it was the same everywhere.
Okay. Yeah, thank you. So here we're in Ontario, we're kind of started again the region-specific reopen and lockdown combination. And I think a big issue is about mobility.
In France, it's also a political aspect. I mean, it's about the law, the French law, that such a measure like lockdown, it seems that the law, it's not be possible. It is not possible to at this time to propose a lockdown, a different date of lockdown according to the different department or region. I think it's there is a problem with the law.
Right. Thank you.
I think Quentin, I think Jeffrey Harris has a question.
Can you hear me?
Yes.
Yes.
Oh, yes. Thank you very much for your talk. It just so happens that last night I submitted a manuscript to medRxiv concerning the heterogeneity in the incidence of COVID in Los Angeles County, which is the largest county in the United States with a population of over 10 million people. And what I did in the analysis is very similar to what you did. I used US Census data, demographic data, to try to correlate with the incidence of COVID, especially in the most recent wave of the disease, which began in late October in the United States and seems to have at least suspended somewhere in mid-January, but which comprised about 2/3 of all of the COVID cases that we've had so far. And my analysis is based on much more micro geographic details, since Los Angeles County is a large population, but within that county, there are 300 communities, which are analogous to the departments of France in your study. And what I found is that certain demographic features were the most important. In particular, the presence of large families with multiple generations, which I was able to reconstruct using census survey data, was the greatest predictor of the number of cases. And the percentage of families that were at high risk in California or in Southern California in this particular county were up to 30% of the households. This particular factor was much more important than other indicators of poverty, but other factors that were important were the presence of households in which low-wage workers were important. In particular, low-wage workers whose jobs could not be done remotely. So I think that this is an important field of cross-sectional analysis of the micro details that breaks through the assumption that everything is homogeneous, because it is not. As an aside, I fed the data that I had into a modification of the standard SIR model in which each community could have its own parameters. And I found first that there in fact was effects of adjacent communities That is, there was a contagion between departments in the terminology here. And also that while there was a global reproductive number for the entire county at any one time, that reproductive number varied considerably among the communities, or in this case, I would suggest among the departments in France.
Thank you, Jeffrey. I totally agree. First, the scale of the geographical scale of the analysis is highly important in interpreting the results. For example, we are trying currently to analyze the data from my city, Marseille, because we are trying to push some strategy case area targeted interventions among people, among families. And we can see clearly that at the very, very local scale in the city, there are some social and economical structures, characteristics that are highly important, that are very important to understand the outbreak. And for example, the second wave, I go back to the last slide. Oops, sorry. Okay, the second wave, we didn't had these data at the very local scale. So we didn't saw, in Marseille, there was, in end of September, there was a plateau, and we didn't see that in the poorest communities, there was no plateau. The outbreak was increasing, and in the richer community, the cases were very lower and decreasing. And this is because, and then the second wave came. The second part of the second wave came. So there is at the very precise scale, there are some comportment, some behaviors and some social structures of the families, of the communities that are very important to assess for studying the dynamic and also for interventions.
Right, so there was a last question from Etienne Pardou. Etienne, I'm allowing you to talk. Right, just maybe a quick question.
Yes, just about this last slide. Jacques, would you take the risk to comment the last part of the curves? Because they don't look so ugly. I mean, the derivative is positive, but the second derivative is a good sign in most of the curves. So do you have any conjecture for the near future, the evolution?
Okay, I take the risk. Thank you, Etienne. No, I have had a very bad experience in end of September. In end of September in Marseille, we had also this plateau, and but we didn't look precisely in deep at the data because we didn't had at that time the data at the very local scale, and we were very confident about this plateau. There was a curfew, and it's easy to have a mask, and the masks are very, very useful. So at that time, I was confident on the evolution of the outbreak. So now we have the same, in my opinion, we have absolutely the same characteristics of the curve, that is this plateau. And we saw it in different countries, a plateau before a very important peak. So even if we didn't had these new variants, these mutations with a highly transmissible new variant, yes. Even if we didn't had that, I'm afraid we will have a new peak next in the few weeks. I hope I'm wrong. Yes.
Okay. Thank you.
Etienne, if I can make a last comment,
Yes.
actually we just submit a paper in medRxiv about this question, and actually we think this is probably the plateau before the mean value on the plateau is very important.
Yes.
And in fact, reducing this value will reduce the amplitude of the next wave, in fact. And that's our conclusion, in fact.
Okay.
So everything seems to go in the same direction, in fact.
All right. Thank you, Pierre, for these last comments. So I think it's time to switch to the next speaker. So Jeffrey, welcome in our seminar. Yeah, okay, thank you. So you can, normally you could start your slides now.